Then I'm going to switch to the screen share, which will be this screen. You should be seeing my screen entitled MAFLD.
Yep.
Great. Metabolic associated fatty liver disease. This is the new word we'll be using for NASH or NAFLD. And this is a very, very useful, I think, tool and term, and I'll get into that in a few moments. Let's see if I can get the forward button going. This is being recorded, of course. We have quite a few slides to go through, so we are going to move fairly quickly. Here's the abbreviations that you need to be familiar with. MAFLD is the umbrella term now for NAFLD and NASH. And steatosis being just fat without inflammation, without fibrosis. The word hepatitis is inflammation. And the next area you have to be thinking about this alcohol use disorder. That's the new term that we use for alcoholism. Very, very important. And alcohol-induced steatohepatitis, alcohol-associated liver disease, AALD, alcoholic hepatitis. And then if you have combined ASH and NASH, we have CASH, although we'll have to think of something now that we have MAFLD as our primary working term. This is a number of overall terms also that we have here in terms of a Venn diagram. And the important thing here is that people with fatty liver, you need to take a thorough alcohol history. When you have an alcohol history, alcohol use disorder, you need to do a full workup for metabolic disease. And then of course, look for secondary causes of fatty liver. There's some rare metabolic conditions, medications that can cause that as well. They'll keep all those things in. This is a continuum of MAFLD, ALD, overlap, steatosis to NASH. This is using some of the older terms. I haven't updated all these slides quite yet. And whenever you hear cryptogenic liver disease, 90% of those are actually going to be MAFLD and 10% autoimmune and maybe 1% something else. So cryptogenic is a term we rarely use now in hepatology. Alcohol and MAFLD rates are both increasing. So alcohol use disorder is increasing, alcoholic liver disease is increasing. The associations with MAFLD are increasing, obesity driving this, of course, with diabetes, hypertension. There has been arguments about moderate alcohol use in people with non-alcoholic fatty liver disease, MAFLD. And there's been some rumors that it's beneficial, some rumors that are neutral, and some rumors that it's going to make it worse. I tend to be in the make it worse category. So I tell patients who have fatty liver disease not to drink. I just basically say there's no known benefit and there's potential substantial harm. So you can see what's happened over the last 40, 50, 60,000 years, and we've evolved to a very problematic state, and our leaders of our country even have problems, I'm sure, with metabolic associated liver disease. This is what I present to my patients about a shorter lifespan, lower quality of life. I talk about kidney injury. There's a direct link between fatty liver and kidney injury, as well as through fatty liver and hypertension, other diabetes, but directly injuring kidney, probably through an inflammatory process. Heart attack, orthopedic problems, sleep disorder, quality of life issues, cognitive issues. Fatty liver is associated with increased risk of at least 13 different somatic cancers, not just liver cancer, but a variety of gastrointestinal and uroepithelial cancers. Liver cirrhosis, liver failure, liver transplant, and death. I usually describe to these patients that by getting to their ideal body mass index, they can extend their life by 10 to 20 years. And it's not just more life, it's quality life. We are not the only hot spot for fatty liver. It's actually the Middle East has a higher prevalence, and the calories, kcals per day, are incredible. So most of us need between 1,800 and 2,400 a day. So you can see how much overeating is present here, and this is clearly going to drive fatty liver metabolic disorders in a very direct way. This is part of the continuum. Haven't updated all these terms yet. So the MAFLD continuum, but you have steatosis, NAFL, NASH, cirrhosis. You can get cancer in F3. So before people are cirrhosis or F4, we start considering surveillance for liver cancer. So abdominal obesity, part of the physical examination is doing an abdominal girth measurement. We're gonna be looking for glucose intolerance, elevated glucose fasting, insulin resistance. You can do something called a HOMA-IR, it's a calculation. There's certain glucose ratios that also people can look at. You can use hemoglobin A1C as a test to look for diabetes, pre-diabetes. Obviously, everybody's gonna get a hypertension workup. Everybody's getting a lipid disorder workup when they're in for a primary care or consultation, of course. Pro-inflammatory, C-reactive protein and sudrate are associated with accelerated complications of MAFLD. Some nice emphasis. So there's cytokines, adipokines, oxidative stress, apoptotic pathways that are all involved with this. And there's a heavy genetic influence I'm going to get to later, but this is an inflammatory state. That's why people who have fatty liver don't feel well, you don't sleep well. Arthralgias, myalgias, a variety of other problems. This is an overview, and this goes into these whole, I'd say, conversations about what's happening inside the liver in terms of inflammatory cells, cytokines, what's happening with lipid disorders, lipid storage, what's being released, what's going on in the adipose tissue. So there's a crosstalk between the GI tract, the liver, adipose tissue, muscle, heart muscle, kidneys, all these things are interacting with each other. And there's a very, very busy trafficking of extracellular vesicles, which will be part of both diagnosis and eventually probably treatment or personalized treatment. So we have an epidemic. I'm going to click through these quickly. 1985. Look at this. Incredible. Also, data missing. More blue. This is not blue versus red, by the way. Blue, more and more people hitting that BMI over 30, 10 to 14%, more than half the US by 1990. Now we're at 15 to 19% in about 20 states. 1997, we're hitting over 20% in 3 states. Now we're over 25% in Mississippi. Now we got 4 states, over 25% have a BMI of over 30. This is almost 20 years ago. A little bit more, 2004. Now we're going to 2007, 2010, 2011, 2012. Look at 2013. Incredible problem. Now we've got 35% of adults are obese in Mississippi. Oh, that one didn't come across very well. It's 2014. So Hispanics tend to be higher, African Americans second, Caucasians third. Others include the Asia Pacific population, less common. I want to highlight here on the right side about doing a thyroid workup on everybody. Young women, you're going to be doing a polycystic ovary workup. There has been advocacy about doing pituitary workup in patients. I have in unusual patients got growth hormone levels, also to do an assessment for these individuals. And of course, I'm always getting a waist circumference as part of the patient's vital sign. We've walked through the consequences. So you're looking at in the US right now, 330 million people in the total population. We have 100 million with fatty liver. You're going to take that down to about 60 million who've got fatty liver with some inflammation and some fibrosis. And you're going to take it down to about 15 million people who are eventually going to be at risk of getting cirrhosis liver cancer. So 15 million people. This is going to keep all hepatologists and all primary care and all gastroenterologists busy for a long time. So why do people progress from simple steatosis to NASH? We're going to get into that shortly. These are more photomicrographs. If you have NASH over 10 years, 10 to 20% are going to get cirrhosis. So that's that 15% of the 60 million that we talked about. All right, but if you have just fat, no inflammation, normal enzymes, it's very likely to be a benign disorder in the liver. But having fatty liver alone increases the risk for insulin resistance and other systemic complications. So fatty liver is never healthy, bottom line. This is a very complex study that was done, but I just want to highlight what's in the title: measuring cognitive changes in people with type 2 diabetes. And there was a link between this cognitive impairment and having fatty liver. So they did cognitive tests, drawing tests, etc. So there is something going on in metabolic associated liver disease, including type 2 diabetes, that changes how people think. Outcomes. So when I talk to patients, I give them information. Once they have fatty liver, if they don't have diabetes, they're going to get diabetes. And you can also use, from the enzyme perspective, GGT as a surrogate for risk of cardiovascular disease and indirectly diabetes risk. So everybody who gets a liver panel should have a GGT as part of that liver assessment and liver workup. Very, very important. The bottom line is fibrosis. Fibrosis drives outcomes, definitely liver-related outcomes and non-liver-related outcomes. This is liver-related mortality. So what we want to do in every patient with fatty liver is to assess how much fibrosis they have. And we'll be getting into what we call non-invasive testing shortly. Very important. This is the fastest growing cause of liver cancer among all types of liver disease and will eventually exceed hepatitis B and C worldwide as a cause of liver cancer. And as I mentioned, liver cancer can occur in NASH patients, MAFLD patients who have F3. So you want to stage people, and you want to find those people with F3, you want to find the patients with cirrhosis, and make even more powerful interventions. This is liver-related and overall mortality in patients with MAFLD. Very, very important that you can see the trend in simple steatosis, but it's really when things get into NASH, and of course NAFLD-related cirrhosis, where you're going to have an increased liver-related mortality, but also overall mortality. Heart disease, kidney disease, cancer are all key leads in that mortality risk. There's some circles highlighting these areas, numbers. Fructose is a big driver, so we have every single patient who's got fatty liver that I see sees a nutritionist. Now that's a little bit of a problem because our wonderful, intelligent insurance companies, which really aren't insuring anything except their income, don't pay for nutrition consults, which is totally bizarre. You have to think about, they'll pay for bariatric surgery at $20,000, but they won't pay $60 for a nutrition consult. And it really takes a multidisciplinary team to get people to lose weight. So nutrition, health consult, primary care, gastroenterologist, hepatologist, endocrine, all need to be working together with these patients. A little bit more on fructose. So we try to decrease fructose to 0. We try to take carbohydrate proportional down to 20 to 30%. Fructose depletes hepatic ATP and has basically a mitochondrial toxic effect. There's a lot more to this, including things called palmitate that are going on, these polyunsaturated PUMA, which are oxidative intermediates that are there, and then different signaling pathways, including this JNK, CHOP, TRAIL. The bottom line is this is a mitochondrial pathology as well as a general cellular pathology. The intestine microbiome is involved. All of my patients with fatty liver, I push them as hard as possible to a vegetarian diet. At least, if they still want to have meat, then it'll be fish-based, really a Mediterranean focus, trying to take red meat down to 0. This does change the bacterial profile to one that's oxidative to one that's reductive, from one that's inflammatory to one that's non-inflammatory. This is just an animal model, but just real quickly, once you give that animal model this carbon tetrachloride and you have this liver injury, it absolutely changes the whole clinical profile of the microbiome. It's really profound. This is a really important slide, and I'll point you to the lower right corner that's here. And the lower right corner of the slide is these genetic modifiers of fibrogenesis. And that is PNPLA3, TM6SF, MBOT, HSD. I don't use the KLF as much, but at least the 4 that are on the bottom are very, very important. And not too far into the future, you can actually order these now, by the way, but we'll have panels through Quest and LabCorp, and that's going to tell you, to be able to tell your patients what their risk for getting cirrhosis is. This also drives liver cancer risk, these genes, especially PNPLA3. So these are important. These modify fatty acid flux, triglyceride levels, a variety of other things that are going on with signaling. So these panels will be important, I think, clinically very, very soon. Okay, so symptoms. They always call this an asymptomatic disease, but that, I believe, is a problem with our insensitivity to how our patients are feeling. You just spend an extra 3 or 4 minutes, you talk to your fatty liver patients, they're gonna feel bad. They're gonna have trouble sleeping, snoring, restless leg, myalgias, arthralgias, abdominal pain, right upper quadrant discomfort. Then you go down to lab assessments. We already talked about all these metabolic issues and liver markers, but they may have autoantibodies, SMA, ANA. I believe this is all part of this inflammatory state. And when you're doing an iron workup, forget about the ferritin. It's going to be 1,000. It doesn't help you with an iron assessment. Iron percent quantification is the key. Imaging, of course, CT, MR, ultrasound, we'll say fatty liver. But if you want to quantitate that, you need to get what's called a fibroscan. We're trying to get fibroscans to be broadly available in Reno. Digestive Health Associates has one, and I'm trying to remember, there's another one somewhere in Reno, but that is a non-invasive test that's useful, and I'll expand on that more shortly. So you want to quantitate or semi-quantitate the fat in the liver. You can do that with the FibroScan, something called controlled attenuation parameter. Take an alcohol, medication, supplement, herbal, over-the-counter history. Make sure you're not missing some competing etiology or coexisting disease. So everybody gets a B, C, iron. Someone's got fatty liver and a psychiatric disorder, Wilson disease. Very, very important. And if it's something strange, like somebody with fatty liver is 28, who's had a stroke or a heart attack, you're going to consider another disease called LALD, lysosomal acid lipase deficiency. Very simple test you can order through Quest or LabCorp. We almost never do liver biopsies unless the patient's in a research study. The academic centers and the guidelines push biopsies on almost everybody. You can't make the diagnosis without a biopsy. I think that's wrong. Somebody's got advanced fibrosis, they've got metabolic disease, they've got fatty liver on a scan. You don't need a biopsy to figure that out. I do a biopsy in people with confusing issues. But let's say somebody has an iron saturation that's persistently over 60%. I'm going to send them for an MR scan to get a quantitative iron. That's the state of the art, not a liver biopsy. So if I have fatty liver plus I suspect autoimmune disease, then I'll do a biopsy. That's the role for a biopsy now. Okay, so we talked about ultrasound. That's kind of a yes, no, CT, MR, yes, no. Sometimes I'll give you a qualitative assessment, but VCTE, FibroScan, vibration controlled transient elastography, is the key. Also, you can get elastography through a 2D or point shear wave, something called ARFE, acoustic radiation force impulse, MRE, magnetic resonance elastography. Actually, I in ARFE, I think stands for imaging, sorry. Computed tomography is qualitative. There is a quantitative test called MRPDFF, protein density fat fraction, but that takes very special software. It's in many of the clinical trials, but I don't know any clinical imaging MR team that has that available right now. And back to the FibroScan with CAP for fat. So MAFLD, often symptomatic. Radiology is a starting point, not non-invasive markers are established to stage fibrosis. That's really what their role is here. And biopsy remains, I think, a silver standard. All right, other clinical factors. We talked about C-reactive protein. That's elevated in NASH. People have an inflammatory state. I think the C-reactive protein is very, very helpful. CK18 you can't get commercially. Everybody you see, a BMI needs to be in the chart next to the blood pressure. That's another vital sign, like the abdominal circumference. Ultrasound looks like this, a little bit darker, a little bit heterogeneous, sometimes texture as compared to the kidney. Blood vessels are blurred. CT scan shows this dark looking liver, and then the vessels are bright. It looks like a contrast CT, but it's not. It's because the background liver is so dark from the fat. So we're gonna get into treatment now. So you could go after insulin, diabetes, you could go after inflammation, you could go after fibrosis. Let's get into that a little bit more. Of course, weight loss is key, right? Weight loss works. Vitamin E, 800 international units a day is key. I give it to all my patients. I think it's quite useful, very benign. Really aggressive about insulin sensitizing agents. I don't use insulin in my diabetics unless I really have to, and I use a C peptide to assess whether they really need insulin or not. So we're gonna start out with metformin in everybody. Wonderfully safe drug, and in fact, it's liver protective. Decreases the risk of liver cancer and other interesting outcomes recently, including cardiovascular events. So metformin is a kind of a magic drug. Then GLP-1, then SGLT2, then DPP, and then we consider insulin. I don't like the sulfonylureas. I don't like a lot of the other older diabetic drugs, and don't like the lidozones at all. Way too many side effects, in my opinion. Lipid-lowering agents. Remember, statins used to have a bad rap. We now know that statins are liver protective. Anti-inflammatory, decrease portal hypertension, decrease the risk of liver cancer, decrease the risk of death due to liver disease. So statins, a cornerstone of managing MAFLD patients. FXR, there's a drug that was supposed to be approved by the FDA this summer. They got a letter, the letter was negative. They didn't get approved. The company just laid off, I don't know, a huge number of people. It's very sad because the company and the investigators and the FDA and what's called the Liver Forum all had specific endpoints that everybody agreed to. The company met the endpoints and the FDA decided not to approve the drug. And we don't know why. I have some suspicions, but I don't know why. Weight loss works. A lot of open label studies, case series, it works. Now, I don't use orlistat. I use diet, exercise, behavior modification, health clinics, regular follow-up, really engaging the primary care providers in this intervention. Surgery works too. If you get somebody bariatric surgery and they lose weight, their liver will get better. I do not use stimulants. I don't use naltrexone, naloxone, the other sort of drugs in that class at this time. Weight loss, more data that weight loss works on the right side, the right graph. NAS change, that's biopsy inflammatory score. More on weight loss, paired liver biopsies at gastric banding 24 months later, mean weight loss. My gosh, I got 34 kilos. Improvement in steatosis, inflammation, and fibrosis. All you have to do is lose a little bit of weight and things start getting better. 7% weight loss to get NASH resolution. Now, I tell my parents to pursue a normal body mass index, but I tell them that even a modest weight loss is going to start helping their liver. This is more on histology after bypass, better fat, inflammation's gone, fibrosis reduced, ballooning reduced. Look at that histology on the left. All that blue is bad. That's on the trichrome stain. Look on the right. 8.5 months later, blue's gone. This tells you how reversible fibrosis is with interventions. Now, this is an interesting study. They had 3,922 people. This is in Sweden. I didn't know there are that many obese people in Sweden, but it's true. Now, conservative obesity management meant an aggressive behavior modification program. Basically, the study said surgery is equivalent to aggressive weight loss program. I thought that was very useful. Problem is, insurance companies will pay for bariatric surgery, but they won't pay for a team approach to modify obesity. Just crazy. Our society, our insurance system needs to change. This is just a little bit more on the graphics on the right side. Kaplan-Meier estimates, follow-up time out to 26 years, different events that are here. Lifestyle modification, weekly meetings for 4 months, and then monthly for the rest of the year. Moderate carb, low fat, low glycemic index, fruit, vegetables, protein, exercise, 30 minutes minimum, 3 to 5 times a week, with a heart rate increase. 154 patients, remission of MAFLD by what's called MR spectroscopy, 64% resolved. Not just got better, but resolved. Isn't that amazing? In the intervention group. More weight loss, much less hepatic triglycerides. That's what this graph is showing. Ketogenic diet. They actually done a series of studies showing that this wonderful, new, trendy, in-style diet actually drives improvement of MAFLD, ketogenic diet. There's a lot of changes that take place with the ketogenic diet with increased triglyceride hydrolysis, these non-esterified fatty acids, acetyl-CoA, redox, decreased insulin, decreased glucose, decreased glycogen. It's amazing, isn't it? Exercise works, really good data, 800 patients divided into their category by METs. Decreased risk of NASH, fatty liver, MAFLD. Isn't that amazing? Doubling time spent in vigorous exercise, up to 150 minutes a week, continues to improve fibrosis. 400 calories per session. It's an hour of vigorous exercise 3 times a week. Immediately you get improvement in insulin resistance. Sleep. Overweight adults sleep more. Isn't that amazing? They lost the same amount of weight. Non-obese, obviously may have been overweight too. If you curtail sleep, you decrease the amount of fat loss. We aid sleep. I believe in the overweight or obese individuals, their sleep may be longer but disrupted. What they really need to do is a study about quality of sleep, even at a sleep center, assessing for sleep apnea, restless leg syndrome, awake sleep cycle, breathing cycle. It's more on lipids, statins, main front line. I like lipid-soluble statins better than non-lipid-soluble statins because they appear to have a better effect on liver cancer risk. Insulin sensitizing agents, as I mentioned, I don't like pioglitazone or rosiglitazone. That whole group of drugs are associated, especially pioglitazone, with weight gain, heart failure, and even a hint that there's an increased risk of bladder cancer. They even tried pioglitazone together with vitamin E in a study compared to placebo. This is actually 3 different arms, sorry. Pioglitazone is a little bit better than vitamin E in 3 of the 4 arms, but look how much better vitamin E was than nothing, placebo. Great. So pioglitazone, weight gain, cardiac toxicity. Oh, I forgot to say fracture risk. Another reason I don't like pioglitazone. So Pivens, vitamin E was good. Pioglitazone helped, but had some bad twist to it. So really, look at this. Vitamin E had a histologic response that was better than pioglitazone, so why not use that? And then you work on the fibrosis with vitamin E, with weight loss. So why not treat everybody with MAFLD with vitamin E? I say we should. but there's some caveats to that you can look at on this slide. This is the new drug we hope will be approved soon, obeticholic acid. This is a Regenerate study. OCA at 10 and 25 was better than placebo for fibrosis improvement and no worsening of NASH. And what you want is fibrosis to get better. Now, these are people with significant fibrosis, stage 2 or stage 3. They did not have cirrhosis. They did not have stage 4. Adverse events, changes in cholesterol, and worsening of pruritus. I'm sorry, pruritus is misspelled here. A lot of other drugs are in the pipeline. Resmetirom is a thyroid beta agonist, elafibranor, PPAR, alpha delta, medication, Ramcall, which changes this SCD1. We like other drugs that have anti-inflammatory, anti-fibrotic properties, including this, what's called belapectin, a galectin-3 inhibitor, or CCR2, CCR5 antagonist, cenicriviroc. Now, when you have a patient with cirrhosis, it's not just cirrhosis. We have 1, 2, 3, and 4 inside the cirrhosis category. So here there's 3 columns. What you want to look at is compensated versus decompensated. Decompensated means bilirubin's over 0.7, albumin's less than 3.5, INR is prolonged, ascites or encephalopathy. Varices is part of that decompensation. You can image for ascites, of course, do a good physical for encephalopathy. Don't order ammonia testing. In my opinion, it's not just worthless, it's confusing. So, this fibrosis of the liver, how do we assess for that? We already have some scar tissue for the structure, and then once you get cirrhosis, it's usually pretty obvious on imaging or physical. Between normal and cirrhotic, we have something called the APRI score, FIB4, NASD. Those scores are all very useful. They're online, and they'll give you a general idea what the fibrosis level is. And if it's indeterminate, you should combine 2, 3, or 4 tests. If that still doesn't clarify it, then you could think about a biopsy. Look at all of these studies going on in cirrhotic patients, heavily focused on anti-fibrotic, not so much on metabolic syndrome, diabetes, or lipid. Lots happening here. So there's a lot of excitement. A little bit more on the fibrosis pathway. And as I mentioned, this is genetically driven as well as behavior, diet, weight. So inflammation is very interesting because it tends to go down over time and the fat tends to disappear as people get cirrhosis. There's a lot of activity going on. Up until real cirrhosis, though, this disease is highly reversible. We talked about GLP-1, liraglutide, what it does, insulin secretion, glucagon secretion management, reduces weight loss, suppresses appetite, delays gastric emptying. All these things can help reverse many components of the MAFLD syndrome as well as managing the diabetes. It's the LEAN study showing percentage of patients, liraglutide in green for NASH, resolution, fibrosis, ballooning, steatosis, lobular inflammation. So the higher the green bar, the better. And some of these reach statistical significance. Other targets of new drugs, TLRs, LPS, NKT. We talked about PPAR, we talked about FXR. And I'm gonna say, hold on just for sorry, I had to change some background sounds. So a lot of other targets in this space. All right, this even goes into more targets. We've targeting lipotoxicity, oxidative stress, inflammation, immune activation, apoptosis, necrosis, lots of excitement. Extracellular vesicles we'll be looking at as both research tools, diagnostic tools, and therapeutic targets. Targeting proteases. Proteases are regulating all these major biologic pathways in NASH. So, we're at the end of the beginning, as Dr. Scott Friedman would say. This is one of his slides. We're understanding this disease. We're understanding MAFLD, the diabetes, the hypertension, the inflammatory, renal, cognitive changes, as well as what's going on in the liver, cardiovascular risk, heart attack, stroke, complications of hypertension. We're coming up with different targets: the brain, lipids, diabetes, the liver itself, inflammation in the liver, fibrosis in the liver. Number 3, I want to expand on just for the last few minutes here before we get to Q&A. NASH is moving away from the biopsy as quickly as possible. Biopsy is required by the FDA for phase 3 studies. But we have these non-invasive tests. You can go online and plug in enzymes, platelet count, age, and get fibrosis by APRI, FIB4, NAFLD score. Very, very simple. There will be some better blood tests coming out soon, one called ELF, which is in front of the FDA right now. FibroScan, extremely useful. How much fat's in the liver? How much fibrosis is in the liver? So these are very, very useful tools, non-invasive tests. I recommend every patient you see with fatty liver, you calculate at least a FIB4 or APRI score and a NAFLD score. These are available through MD Calc. A lot of new therapies will be coming out in the next 5 years. They'll be focused on the patients with more advanced liver disease, probably due to cost and risk-benefit ratio. So I think last slide is this summary slide. I think we've talked about all these different issues. I think everybody with elevated liver tests gets tested for fatty liver. Every diabetic gets tested for fatty liver. Everybody that's obese gets tested for fatty liver. Stop smoking, stop alcohol. Coffee, tea, sleep are great. Any other points here? We talked about a weight loss goal of 10% at a minimum, normal BMI best, exercise 3 hours a week, vitamin E, statins, bariatric surgery in people for a BMI over 40. All patients should be seeing a dietitian, nutritionist. Weight loss contract I use, something they sign, fructose-free diet, vegetarian preferred, Mediterranean diet, great. And I don't, at least I ask my patients not to drink out of plastic water bottles. These BPAs and other bisphenols are metabolic disruptors and can result in fat accumulation and insulin resistance and really change our genes. A lot of people help put these slides together. Hope this is good for you all. And if you need more information, we can do a Q&A. Thank you.